Hi everyone, I'm Tess and this is part 2 of the donor unit testing presentation for Hep B, Hep C, HIV, and HTLV 1 and 2. My partner Brooklyn took care of part 1, which covered the objectives and hepatitis B and C, so now we're going to jump right in and start with HIV. In the very simplest of definitions, the human immunodeficiency virus, or HIV as most people know it, is the causative agent of AIDS. Its primary function inside the body is to attack the T helper cells, or CD4 positive cells, which wreaks absolute havoc on the human immune system. Currently, unfortunately, there is no effective cure, but there are many treatments available that can help delay and control the HIV disease process in a person's body, and so much research is being done on this that these treatments are getting better all the time. HIV can be transmitted through a number of body fluids like blood, semen, or even breast milk, and a few of the most likely ways a person might contract HIV would be through sexual contact with an infected person, contaminated needles used in IV drug abuse, or, and this is what we'll focus on in this presentation, transfusion of blood and blood products. HIV-1 antibody testing was originally implemented for use in blood donor screens in 1985. This was right in the middle of the AIDS epidemic, and just a year or two prior, scientists were still trying to figure out where AIDS came from and how it was transmitted. So when this test was finally implemented, it was a huge step in the right direction as far as patient safety and transfusion was concerned. A few years later, after a second HIV antigen was discovered, or HIV-2, antibody testing was added for that as well in 1992. And finally, in 2002, the first NAT, or nucleic acid test for HIV, was approved by the FDA. The implementation of this screening, along with the use of HIV-related questions in the donor questionnaire, has drastically decreased the risk of HIV transmission via blood product. So much so that the current risk of contracting HIV via blood transfusion is very small, with the current ratio being about 1 to 1.5 million. There are 2 initial screening tests for HIV. The first is searching for HIV antibodies, so both IgM and IgG antibodies for both types, HIV 1 and 2, and that is performed using a chemiluminescent immunoassay or an enzyme immunoassay. The second screening test is looking for RNA for the HIV 1 antigen, and that is performed using nucleic acid testing, or NAT. And polymerase chain reaction testing is the most common type of NAT that is used in these donor screenings. It's also interesting to note that the same NAT that they use for the HIV-1 RNA test is the exact same test they use for the hepatitis B DNA and the hepatitis C RNA test as well. So all 3 of those tests can be used in the same assay, which makes our blood donation testing just that much more efficient. If that test comes back negative, that's great. Obviously, there's nothing to worry about. If it comes back positive, they're able to do a differentiation to decide which virus is causing that reaction. Another thing is the American Red Cross was trying to add or implement HIV-2 RNA to that same NAT, and their plan was to do that in 2020. But I was trying to find information online about it and couldn't see whether or not COVID had affected their effort in that implementation. HIV 1 and 2 confirmatory testing. So patients that test antibody reactive are further tested to rule out false positives and differentiate which antibodies are causing the reaction, be it HIV 1 or HIV 2. That confirmation testing can include a Western blot test, an immunofluorescence assay, rapid testing, which just helps differentiate which HIV is causing the reaction, or another enzyme immunoassay, and that is just for HIV-2. Also, per the American Red Cross, in their procedure, if both the antibody test and the NAT are reactive, no further testing is performed. They're able to rid themselves of that blood product. Okay, so this is a very, very oversimplified representation of HIV marker levels in early HIV infection. There are so many different antigens that they are keeping track of during this disease, but for our purposes in blood donor testing, we're just focused on these aspects right here. This is all we really need to see. So if you imagine on the x-axis that 0 is the initial point of HIV infection, then you can see that RNA starts to become detectable at between 7 and 10 days. And Justin in his notes has 9 days as when it's detectable. So we're going to leave it at that. 9 days is when you're first able to detect RNA of HIV at a good level. You can see too that IgM doesn't even start to be produced until around 22 days after infection. So that's super important. The fact that we're able to detect RNA almost 2 weeks earlier than we're able to detect any HIV antibodies is super important for testing, because as Brooklyn talked about, the window period between initial infection and the point where virus can be detected, this is where blood product is at the greatest risk. If you have somebody come in who's been infected with HIV and they don't yet know it, or they're not yet detectable, that is where the blood supply is at the greatest potential risk. Okay, on to HTLV 1 and 2. HTLV stands for human T-cell lymphotropic viruses, and just as a quick definition for all of these, HTLV-1 causes T-cell proliferation with persistent infection, and it can also cause adult T-cell leukemia and lymphoma, or ATL. It's also associated with a bunch of neurological diseases, one of the most important or prominent of which being the onset of HTLV-associated myelopathy, or HAM, and HTLV-2 may impact the development of neurological diseases. There have been numerous studies on HTLV-2 to try and figure out exactly what it does, but as of right now, not enough evidence is provided for HTLV-2 to make it clinically significant or of a lot of clinical concern. And last of all, HTLV-3 is only included because it is the former outdated name for HIV, which we just talked about. And that's only important because if you're looking up documents for HIV, a lot of times they'll refer to it as HTLV-3, and that's really what they mean. HTLV transmission is much the same as HIV transmission, so a lot of it's through body fluids. There is a high number of studies that talk about mothers giving their children HTLV through their breast milk. Sexual contact with an infected person can also put you at risk, as well as contaminated needles used in the IV drug abuse, and also, of course, transfusion of blood and blood components. There have been reports of transmission rates of up to 63% from transfusions of blood from a donor with HTLV-1. That's cited in multiple studies, and that is prior to when HTLV testing was introduced to the blood donor screens in 1998. Because of that introduction, the current risk of getting HTLV from a blood transfusion is 1 to 2 million, which is even less than the risk of getting HIV. There is only one screen available for HTLV testing in blood donation, and that is the antibody for HTLV-1 and 2, the IgG antibody, and that's performed using a chemiluminescent immunoassay or an enzyme immunoassay, and there is no NAT available for HTLV. Confirmation testing includes immunoblot, which is most likely or most commonly Western blot, and also indirect fluorescent antibody, IFA. Another interesting thing to note about HTLV testing is that HTLV is the only infectious disease testing that is not necessary to perform on plasma products or during plasma donation. This is because plasma of patients infected with HTLV-1 is currently considered as non-infectious. Right, that is the end of the information that I have for you in this presentation, so now it's time for just a really quick review. Of all the slides in this entire presentation, I would say this is probably the most high yield, as it has all of your pathogenic agents, all the markers, the test methods, and the confirmation testing that you need for each one. So definitely in your studies, I would use this slide, as well as I would go back to Brooklyn's half of the presentation and grab the chart that she has about the window periods for each test as well, for HBV, HCV, and HIV, as that is likely to also be very important. Thank you so much for listening to this presentation. We hope you learned something, and good luck with your studies.